So we're here with three movers and shakers in the world of neurology and HIV. To my left we have Bruce Brew from Australia. We've got Serena Spudich from here in the United States, and Scott Latender also from here in the United States. So I think I'd like to start off just with you, Serena. You gave the plenary talk today here at CROI, which it's been a long time coming that neurology has been a subject for a plenary. It's happened in the past, but not in the recent years. So how did that feel, and what did you, do you think you got across what you were hoping to get across?
Well, thanks. I think that the way it felt really is sort of a validation of our field, and I hope all of our colleagues felt that way, that realizing that the community of investigators and providers and even the community in general was interested in hearing about neurology at this point, I think really reflects the fact that there's been a sort of resurgence of interest in what's going on in the brain. As people are aging and as people are having sort of control of the virus, they're starting to realize that there's still at least some potential concern about what's happening in the nervous system, and there's a lot of attention being paid to that, which I think is new. The other thing that's of course of interest is whether or not the brain is some sort of a reservoir that has to be addressed in cure strategies, and that's become a very exciting area for a lot of people. And how it felt, whether or not I got the information across, I hope so. I think that the idea really was to have a review of the field, and I tried to cover a lot of topics and a lot of the work of my colleagues here and all sorts of colleagues who've worked in the field for much longer than I have.
Yeah, well, it seemed from the audience response that I was noticing that there was quite a bit of interest, and I know that the neurology session that took place yesterday as well. The three of you were in the room and actively got up and spoke in the microphones and asked questions, and it seems like there was some emphasis on different things than had been in the past. A lot to do with neuronal injury, depression, and maybe a little veering off of the track of what at least I've seen in the past. And I don't know what you think about that, Bruce. You've been in this game for as long as anyone in this room, anyway.
Sure. No, I think the emphasis has changed from years gone by. Years gone by, there was a strong emphasis on the severe end of the spectrum of the disorder, the dementia, and how you'd characterise it and how you'd treat it appropriately and predict its occurrence. Now, with modern therapies, the disorder doesn't really occur to any extent anymore, except in patients who fail all their antivirals or who come to treatment late. So the emphasis now has shifted to the much milder end of the spectrum, and that's been the shift throughout neurology, in fact, trying to identify things at a much earlier phase, and even in patients who are at risk but not affected. So that's been a major shift, and I guess the other shift has been towards considering potential toxicities for antivirals. It's a thorny area, and I think people, whilst there is some evidence for some toxicity with some of the drugs, I think it still has to be very carefully considered.
Yeah, and I think there's a lot of feeling, probably among the HIV community, that all drugs are toxic and that everybody has neurotoxicity and cognitive deficit, if not impairment, or greater, and that doesn't necessarily seem to be the case.
No, I completely agree. So I think it's really important to emphasise that cognitive impairment occurs in some patients, but definitely not in all. And that's really an important message to get across.
Yeah.
And I think the other important message is the whole issue of toxicity of the antivirals is a tough one. It's tough because the drugs are good, but they're not perfect. and you can misconstrue toxicity for partial efficacy.
Well, and people are aging too, so there's definitely going to be some effect of just the normal aging cycle. But Scott, I know you've done a lot of work on aging and how it affects the brain. What are you seeing in that?
So you've touched on very good points, and I think the central theme here is that even though we have very good antiretroviral therapies now, we are seeing persistent nervous system problems, or even new, in people who seem to be otherwise effectively treated. So I think that's what the field is trying to address, is in part, is what are the correlates of that? Why is that happening? And so you guys have touched on nervous system toxicity. I think it also is probably very important about when we start therapy. And so the HIV field has been moving towards earlier and earlier initiation of therapy. And I think that's been empowered by having better and better drugs that are more potent and less toxic. That makes it much easier to recommend to patients that we start therapy early. And so starting therapy earlier, unfortunately still we're seeing about 30 to 40% of people in the US who present late in disease for the first time. So we want to go out and be diagnosing people earlier so we can get them on these more potent therapies earlier and protect not only their immune system but their nervous system as well. And so in addition to more potent therapies started earlier, aging is probably another important issue that you mentioned. So as people are on these therapies and their survival is better, their body is changing. And there is evidence from a number of investigations now that not only does the nervous system seem to be aging prematurely, but other organ systems as well. And probably those are all related. They seem to be linked perhaps centrally to changes at the level of monocytes and macrophages, as well as the vascular system, endothelial cells.
Yeah, and I guess we're all getting older, with the exception of Serena, of course. But there was a statistic that you threw out in your talk this morning. The numbers, I believe, were 18% to 50%. You gave that range on. Is that what that was?
What that number represents is the prevalence of impairment diagnosed, by this criteria determined by an expert group that involved, I think, both of these two, saying that impairment was a certain level of performance on neuropsychological testing below the norm means in uninfected people. And so those percentages were the prevalence of impairment that had been determined in different studies in different contexts. So, for example, I think it was your study with SET, is that right?
Yep.
That had 18% impairment
Yeah.
after correction for control for
Getting rid of the confounders,
all the confounders.
making sure they're all virally
They were all
suppressed.
suppressed. So this is in one study, really looking carefully at sort of the what might be thought of as the optimal group that have no other factors that may be affecting cognition. The upper numbers of more like 50% or even more being in a group where maybe more of a real world slice that have a lot of other factors going on at the same time. They may also have had a remote history of substance abuse. They may not have a perfectly controlled viral load. Those numbers have been seen in those kinds of contexts, including the Charter study. So I think actually that information coming from those sources is kind of it tells you different information. One is telling you what happens if you look out in a typical clinic and you sort of see a cross-section of who many of the patients I see, for example, in New Haven, they're more like the Charter patients. What I think Bruce's studies and other studies have done have looked more like trying to understand what is really the effect, maybe more just of the virus. So maybe that's where some of that range comes in. Some of the range also comes in by testing strategies and other kinds of information. But it's basically saying that there's some impairment that's detected in people on therapy within that range.
It's a lot of people quibble about the numbers and get really hung up on saying, my study says 20%, your study says 40%, you're wrong and I'm right.
Yeah.
It's so dumb. And it's revisiting an argument that was contested years and years ago, back in the late 80s and early 90s. And I think it's completely pointless. As Serena said, the data essentially show that yes, impairment exists, despite good drugs, despite viral suppression, but it doesn't happen in all people, but it happens in a significant number of people. I think that's the message.
I guess the gold ring would be to find what mechanisms point to this, and if there's a protective measure that we could identify and explain some of this. But it seems to me that when you have such a vast number that you're looking at, where you have people that may be experiencing some kind of cognitive impairment, people that may not, some greater than others, it also points to how nebulous the whole specialty of neurology can be. And I know that for instance, Serena is on the CURE TSG for the ACTG, and I know you've both done work with CURE as well. And it seems that physicians and investigators that are looking into these strategies are probably even more prone to not understand the brain. So it's got to be somewhat of a challenge to work with people that don't understand what you do. And is the brain a reservoir? And at this conference, we've heard John Coffin take umbrage with the word reservoir, because that needs to be deciphered even further. How do you see that fitting into CURE work?
Well, I think any high ideal like CURE has the effect, because it's such a high hurdle and would be such an achievement for the field, of bringing people together. And I think in no small part that's teaching us for us to understand more about immunology and DNA reservoirs in cells, and is causing our colleagues who work more in immunology to want to understand more about the nervous system, because they recognize that any attempt at cure will not only have to eradicate HIV from glial cells in the brain, but we'll have to ensure that any intervention we make that's focused on cure will also not injure the brain. And so, these are, I think, two of the really central tenets of that sort of work, and is really bringing us together more than bringing us apart.
It's not unique to HIV. I mean, it's a consequence of having a disease that affects you generally, systemically, and has the brain as an involved structure in some people. And so it becomes an issue of turf to an extent. So you see the same thing in systemic lupus, for example, where the disorder is handled by immunologists or rheumatologists. The brain gets forgotten about, and yet it can be exceptionally important. So I think it's a personal thing in terms of expertise, but it's also a disease-related phenomenon that we, across disciplines, have to come across and deal with.
Well, it may well be turf, but it also seems to be funding. There's challenges in getting funding for any research, but it seems to be a little more difficult sometimes to get a brain component or a neurological component into some of the cure studies as well as other studies.
Yeah, I think, though, it's interesting that I think that in terms of something like the NIH, which funds many of these types of projects in the US at least, there really has been an effort, I believe, in my experience, for different, there's often different funding relegated to an institute that typically funds brain type research versus an institute that typically funds, lymph node and gut and other type research. But in my experience in the last couple of years, there's been such an intense interest in this area from all levels, including the NIH, that there's actually been an interest in looking at these things together, and actually a sort of active, proactive effort on their part to say, look, if you're looking at these reservoirs, we want to coordinate and fund brain reservoir studies. So that's happened within the ACTG.
That's great. And if you're having a kick and kill strategy for eradication research, presumably you're going to start an inflammatory process that you know, inflammation in the central nervous system is a lot different than inflammation elsewhere in how bad it could be as an outcome.
Right, right. I think that's what Scott was referring to earlier,
Yeah.
talking about, what's the toxicity or the effect that could happen in the nervous system. I think all of us are sort of concerned
I
about
think
that.
everyone's concerned, that's right. But conversely, you know, not everyone has involvement of the brain. So it's not surprising that that the Berlin patient is okay. And it's not surprising that some of the small studies that have been reported in this meeting and other meetings using HDAC inhibitors and finding nothing happening in the brain, I think that proves nothing. It just validates the idea that only some people have brain involvement. It doesn't give a carte blanche to say these studies are negative in terms of brain involvement, so let's go for it. That's the wrong conclusion.
Yeah. The other gold standard thought to be in the cure strategies are acutely infected individuals, and there are some differences in acute versus chronic infection with regard to neurology and also some of the biomarkers. What are the thoughts on that?
Well, Serena's and Victor Valcour are doing wonderful work in Thailand looking at early infection and presented very nice data at the conference that I'll just touch on, but she should be the one to elaborate on. But briefly, they showed very nicely that if you identify people very early after infection and initiate therapy early after infection, that you can return their levels of inflammatory biomarkers and neuronal injury biomarkers towards normal levels. So.
Yeah, actually, I think we've all been interested in early infection for a long time, and in fact, some of the initial studies that motivated me to be interested in this are some of Bruce's early reports that were case reports. So some people actually have overt neurologic syndromes right after they have seroconversion. And this is something that you've described and others have described that really suggests a sort of very active involvement of the nervous system, probably an autoimmune type response. But I think what the studies that Scott's referring to, we basically have been able to see in these patients with very, very recent infections, so within the first 2 weeks or so of infection, that we can detect HIV RNA in the cerebrospinal fluid, suggesting that there's some invasion into the CNS compartment of virus. But even though the virus is getting in and seems to be there in fairly high levels, that doesn't seem to have instigated at that exact point what we're detecting is active neuronal injury. So you can see inflammation, but we don't see elevations in a marker that suggests damage to the neurons. And then if those subjects in that study are actually all treated acutely within the day after we assess them, and when we follow them up at 6 months, they still look, the inflammation that we initially saw has resolved. The virus is undetectable, although that's true in many patients starting treatment in chronic infection as well. But the inflammation really resolving and these markers of neuronal injury staying normal, I think, is the sort of compelling data, which sort of reflects, I think, a lot of the other reservoir type data, if that's okay to use the word reservoir, looking at levels of HIV DNA in the gut and that kind of thing. It really looks like, the earlier you start, the less reservoir has been established. The same concept may be true in the brain. The earlier you start, the less sort of local infection, inflammation has been established, and so it's easier to control it.
But unfortunately, you have the challenge of being able to access reservoirs in the rest of the body
Right.
through biopsy, where you can't very well do that in the brain, and so you only have to go off of what you can pull out of the cerebrospinal fluid. What has been learned upon autopsy as far as the reservoirs or?
Well, I think there are good data saying that the brain is a reservoir in some patients. I mean, I think the data are pretty strong, and they've been around for quite a while, showing integrated DNA in glial cells. And the most compelling data, I think, are the fact that you can have infection in astrocytes, one of the component cells of the brain, which are unique to the brain. don't have anything to do with the periphery. And there's always been the issue of what's the turnover of cells that are infected in the brain at autopsy. Maybe they just come from the periphery and it doesn't really represent a true reservoir. But I think the astrocyte data are a strong argument against that. There's also been, and there's still controversy as to whether other cells within the brain are truly infected. But I think the astrocyte is infected. I think the data are strong. And I think but only in some patients, not all. And I think that's the most compelling set of data to say the brain is a reservoir.
And haven't I heard somewhere along the line that not here at this conference, but in the past, that astrocytes are very, very difficult to access and potentially clear virus out of, even maybe with work that you've done on drugs that do penetrate the central nervous system?
Well, it's hard to look specifically in living people at specific cells. So there's some technologies that allow you to look for biomarkers that carry with them indicators of what type of cell they came from. And astrocytes are the most populous cells in the brain. So, just by sampling in CSF, we would expect them to produce a fair amount of the biomarkers we might find there. But it's very hard to do in life. Currently, I don't know if, I know there are some imaging methods that allow us to look at microglial activation. I don't know if there are any that allow us to look at astrocyte activation and make an inference about whether astrocytes are infected or not. But mostly that sort of work is going to come from people who've passed and looking at their brain tissue.
And there are some data that certain antiviral drugs work better in astrocytes than others. So that's another reason for being suspicious of the whole negative impact and negative perception of the brain as a reservoir. I think it confirms more that the brain is a reservoir.
Difficult to access, though.
Absolutely.
I think that brings up something. Just hearing all of us talking, this, we haven't had biomarkers as a big theme at this meeting. We have a couple of years ago, and I think it's something that all of us have been interested in and all of us are talking about. But I think that's one area that we need sort of new collaborations, new people who maybe focus on biomarkers who are not in the HIV field but are in other types of neurology fields, because I think there's such a huge development in all sorts of new technologies and assessing processes that are going on in the brain, and we need to apply more of those. I think we need new methods, whether it's some very specific PET ligand. These all involve participation of research subjects in these kinds of studies to validate them and to use them. But I think that's still such an issue for us. We sort of all have the same panel of things that we use.
We've got a lot to learn, I think, from the Alzheimer field in a whole lot of ways.
Yeah, Alzheimer, and I think MS, multiple sclerosis. There's a lot of really interesting research done looking at all sorts of ways to measure brain involvement and.
So more assays. Lastly, I wanted to just touch on depression and HIV and the brain. There's been some data presented at this conference on that.
So much of the field has focused on, including us, on neurocognitive impairment for a long time, and it's important, but it has become milder with time. And perhaps less common, particularly if you start therapy earlier. But depression has been as common, if not more common, and continues to be common among people with HIV. And so there was a nice analysis by Edward Hammond from Johns Hopkins looking at the relationship between viral loads in CSF and depression, showing that people who are on therapy and have detectable levels of HIV in CSF are more likely to have depression and perhaps develop depression in the future. And so I think that highlights an important issue. It perhaps makes the argument that therapy that's more effective in the nervous system may better treat depression, but importantly, we also have a whole several classes of antidepressant drugs. And so I think as clinicians, people who treat patients, we have to be willing to look for this condition and consider its causes and treat it appropriately.
Well, and when you see the data that was presented that shows that those on antiretroviral therapy had lower depression scores, that
Right.
begs more work.
Right. Yeah, I think that the issue of depression is really compelling, and I think that when we see that, you know, I have a natural history study watching people during the early stages of infection, and one of the things we monitored was depression. And in my sort of expectation, I thought there may be a lot of anxiety and depression when people are first diagnosed, and this would resolve with time. And in fact, in our cohort, over 2 years of follow-up or so, there was no improvement in depression scores over time. And there was really a high degree of, you know, clinical depression based on a very simple inventory, but to me that was incredibly disturbing data.
Wow. Well, hopefully in the coming years we'll be able to have happier news on the depression angle.
Yeah, right.
So I want to thank you all. It's been really, really wonderful having this chat, and thank you for all the work you do. Congratulations on your plenary
Thanks, Andy.
presentation, and I hope that you enjoy your trip back to summer in Australia from this snowy Boston winter that we're having today. So Dr. Latender, Dr. Spudich, Dr. Brew, thank you very much.
Thanks, Andy.
Pleasure.